Assalamu alaikum wa rahmatullahi wa barakatuh. Very good evening. Welcome to another edition of Health Matters. I'm Khawa Solomon. With me today is our in-studio specialist, medical specialist, and we'll introduce them to you in a few seconds. But do remember that this topic today is very specific and very interesting. It's something that you might suffer from, you have suffered from last week, today, somebody that you know. Why do we get pins and needles? Pins and needles, is that what we call it? Yes. What it medically commonly called, we will find out in a minute or so. We do want your interaction. So please do call us live in studio. And we have vascular Professor Pillay, vascular surgeon in studio with us, as well as our resident host, Dr. Yaqub Esak. Assalamu alaikum to you. And a very good day to you, sir.
Thank you.
Thank you so much for joining us and making the time. Pins and needles. But before we get into that, tell us a little bit about yourself, Dr. Yaqub. Sorry, Professor Pillay. Professor Pillay, let's get this right.
As you said, I'm a vascular surgeon, and I'm still involved in teaching and training within the country, and so I've got a large academic interest. And I work at the Donald Gordon Medical Center.
But Dr. Yaqub, if we could just quickly direct a just brief introduction to pins and needles, we call it that. Is that the correct terminology? Is that what it should be called?
Well, that's what the patient will present with. He'll say, I'm feeling pins and needles, either in his arm or in his legs, or both. And medically, we'll call it paresthesia. That's our term. Yeah, it's a little bit of a long word, but
sounds like anesthesia. So
this is anesthesia makes you numb. This is paresthesia. So there is some kind of link, because obviously there are other syndromes which Prof will talk about where they're associated symptoms. So sometimes they will only talk about pins and needles, but then the doctor or the health practitioner will inquire further, and then other symptoms and associated symptoms will come through. When they just say pins and needles, obviously it flashes some quick things to us, which I'll ask
we know
Prof,
what it is.
and your immediate thought, which will come to, and things like diabetes. So,
But quickly, before we get to that, Professor J. Pillay, tell us what exactly a vascular surgeon does.
Well, vascular means vessels within the body.
Everywhere.
And you have pathology or illnesses that afflict vessels, and it's our job to sort of put it right. So it's modified, sophisticated plumbing, if you want. So pins and needles may be related because nerves, so pins and needles are caused primarily by damage to nerves. So it's not a vascular anomaly primarily. So a nerve can either make you feel, so you touch, pain, pricks, or you can move as a result of nerves. So if that is afflicted by trauma or inflammation, any sort of biologic injury, and then you have a symptom like pins and needles. So it's related to vascular surgery because a vascular anomaly can give you pins and needles, but it's not the only cause.
So what exactly is that feeling that we are getting, that sensation?
Yeah, I think you've touched on it, but it's not, the entire issue is that paresthesia is a syndrome. So it's not, we say pins and needles, but it's not just pins and needles. So it's a burning sensation, so it's a lack of feeling, so it's feeling of insects crawling on your skin, so it's an entire syndrome. So it really depends on how much the nerve is injured before you feel a particular symptom. So tingling, for example, is nerve injury. So I think it's a layperson's term, sort of pinpricks, but it may not only be that. It's a whole range of symptomatology.
So explain to us what is happening, because you say that the nerve could possibly be damaged.
So I think the easiest way to explain it is that if you're sitting in an abnormal position for a long time, let's assume you're sitting cross-legged on the floor, you may cause external mechanical injury or pressure to a nerve. So the nerve is inflamed, it's injured, there's pressure on it, and suddenly you get up and you can't walk. So you have that numb sort of pins and needles effect. Now, if so like,
don't touch me.
Yes, exactly. So you can't walk for a while, for example. Now, that's not pathological. In other words, that does not need treatment. It goes away after moving around when the inflammation goes away. But then you have disease processes like diabetes, as you touched on, or connective tissue disease, or systemic illnesses that can afflict nerves. And in this country particularly, diabetes is probably one of the most common causative agents for pins and needles, or as you say, paresthesia. And it affects a large proportion of our population in South Africa.
Okay, so before we get into the chronic condition where this does arise, when should one see the doctor? Because if you're going if you continuously sitting and every day you have to sit in a certain position and you get these sensation, pins and needles in your feet or your legs. And as you said, when you get up, it goes away, but then sensation is quite numbing and painful as well in a sense.
I'll just give you an example for the viewers. You know, when we're sitting in mosque, there's a certain posture you sit in, which is called your tashahhud position, right? Yes. And sometimes you're sitting in a long lecture, for example, and listening. So you will find the person will feel the pins and needles sensation, and then he'll wriggle out of it, sit in a different position. Yes. You have to stand, and as Prof said, have to move around. So that's the feeling you get. Most people will get that at least once or twice in their. And as they get older, they feel it a bit more because there's some kind of compression occurring. But like you said, it's not always a medical condition. But once you find that it's happening very often and it's becoming a bit more frequent, then you become alerted that, look, this used to happen only when I used to sit for maybe an hour in the lecture. And suddenly now I barely sat for 10 minutes and this thing is coming up. So there's a change in what is going on in what you're doing. And people tend to also delay their visit to the doctor because they kind of attribute it to, it's just something passing by, it happened to me before, then they take some self-medication. So the point is, like, if something is recurring, it's becoming a bit more frequent, and there are other symptoms now starting to come with it, then we shouldn't delay.
Okay, you're scaring me a bit there, doctor.
Not really. But what we're trying to say, and Prof will agree, but he'll elaborate a bit more, what we're trying to say is in anything, like even people who have headaches, right? Until you've excluded the cause of a recurring, I'm talking about something that happens often or it recurs, then don't just take your medication and assume, okay, it's fine, it's worked. Your symptoms may get relief, but there may be an underlying cause.
Okay.
That's what we're trying to say.
So I'm going to just throw it out there. For example, every time I go to a lecture on a Tuesday morning, for instance, and I sit in that position, cross legs or with my feet on the side, and I get that sensation, I have to like kind of, continuously touch or, wiggle my feet so that the numbness doesn't get there. And it happens within the first 5 minutes of sitting like that. What is happening?
It's merely compression of a nerve. Now, the issue is that in your case, it's transient. In other words, it's for a short period and it gets better quite quickly. And that's unlikely to be pathological. Now, because you can identify a cause of mix and you're sitting abnormally. But if you're doing something that's normal, in other words, walking around and you're getting pins and needles in your leg, or you're lying in bed at night and it's there all the time, then you're not doing anything to incite the issue. And that's when you need to look for a disease process.
All right. So let's talk about other associated possibilities that women often, if men as well in that category. You've mentioned the diabetes. Would that be on the top of the list when there are that sensations?
Yes, I think if you look at population groups, then I think the commonest that we see in this country, and I'm referring to South Africa predominantly, would be diabetes, probably followed by some sort of traumatic injury to the back. Now, meaning that you have some sort of discoid lesion like arthritis or a disc degeneration that gives you entrapment of a nerve. In that case, you'll get it specifically in the legs, or if it's very high up, you'll get it in the arms. Specific to South Africa, there are things like HIV that can do it because it's an inflammatory condition. There are some very specific drugs, TB drugs, that can do it. So, and there's connective tissue. I mean, there are over 30 causes for this, but I think concentrating on the more common ones that the population sees is probably the way to go.
So Dr. Yaku, quickly, could you come in there and sort of guide us when somebody comes in and say, listen, you know what, I really can't handle this pins and needles. Is there anything I can do medically? Is there a tablet you can give me? Can I have to, of course, change my position and not sitting a certain way?
So like we did with the previous show, right? Yeah. In all of medicine, a good history will indicate which direction you'll go. So in your case, if you came and you said, look, it's only at this specific time, then we can attribute it to your posture and its compression. But like Prof said, it's happening at unusual times, or there's a different type of pattern to it, then we'll then have to explore, right? One of the common things we see in GP medicine is pins and needles in the hands, and we just inquire, did you have a car accident before? Did you have a whiplash? And as most of us will have a little jerk or something, a little bump of bashing. We'll refuse to wear the collar because it doesn't look so aesthetically nice.
Yeah.
And then down the line, you find that malalignment of your spine has caused that compression. So we'll take a detailed history, and again, as Prof said, the trauma is second to possibly diabetes. Diabetes is extremely common. It's a world epidemic, outstripping every other disease. So the first thing, I mean, it's so easy in the primary care setting to do a quick sugar test, either fasting, or if you get a random one on the spot they have eaten, we can repeat it. So that would be the thing. We'll get a good history, we'll do some quick screening tests, and then establish. And a fair percentage will turn out to be diabetic. And then in the context of our country, a fair percentage will have HIV. They'll probably admit to it if they've had it. And then again, the HIV medicine itself is also causes a lot of what we call peripheral neuropathy. That is the term for the nerve damage. And the older drugs used to do that more often than so they're trying to get away from the side effects. So we'll do a thorough history, thorough examination, try and exclude the common ones. And then until we get an appointment with the specialist or with the further investigations, either with blood tests or imaging techniques that will be needed, we may put them on some medication, but that will be more symptomatic relief. And patients will probably identify some of the names, like we give is a little blue tablet called Trapeline, there's another one called Lyrica. So we may do that and see. And sometimes that is called trial of treatment. So if they respond to that, then we say, okay, we may be on the right path.
All right, we need to take a break, guys. And when I come back, Professor Pillay, we'll go through sort of the nitty-gritties of this pins and needles. Is it, only in a certain age group? Do children get it? Who would be likely to suffer from it, and so forth? We are taking your questions in this edition of why do we get pins and needles, that numbness, that sensation, like something's crawling under your feet and up your legs. We'll ask more of that just after the short break. Do stay with us. Assalamu alaikum, a very good evening. Welcome back. This is Health Matters. Remember, you can also catch our shows on YouTube. Just Google Health Matters ITV Networks and any of the shows that you've missed. There's something like 7 seasons on YouTube, medical shows, taking you right through with our resident host as well from the IMA. We do thank the IMA for their contribution always in the production of Health Matters. So in studio today, as we unpack what exactly pins and needles is, why do we get it, we have vascular surgeon Professor Jay Pillay, as well as Dr. Yaqub, our resident medical specialist in studio with us from the IMA. So just to get back quickly to the sensation, why we get it, what is happening, the sort of age group that gets it. You often hear older people, the adults complaining about it, not often children that says, I've got pins and needles. Do they actually get it?
I suppose it's possible, but it's not a common thing. Unless there's a motor vehicle accident and there's trauma or sport injury, they may compress a nerve. But as a general comment, I think the older you get, the more afflicted you are with inflammatory conditions. So if you look at diabetes, it's an older age group. If you look at back problems, it's an older age group.
Yes.
So the pins and needles symptomatology would be greater in terms of a rate in those age groups. There are some unique situations like type 1 diabetes, for example, which will affect a younger population, so they're afflicted, or connective tissue disease in younger women. But by and large, I think if you're looking at entire populations, it would be an older age group. So your risk of pins and needles will be higher the older you become.
Okay, so you're saying the kids do actually get it?
They
might not just complain about it as we...
I mean, it's as I say, it's such a wide symptomatology. So if your kid arrived and said, "I've got some funny feeling in the leg," and you'll say, "Just run it off," and you won't feel it. But we must be mindful that diabetes can affect children, for example.
Okay.
So inflammatory disease processes can affect children. Children can have liver dysfunction, renal dysfunction. So in those unique instances, they may be able to, but. I think under those circumstances, the overall disease is so serious that the pins and needles may not be sort of identified. Not the primary issue,
Dr. Yaqub, does patients often come presenting, the diabetes situation and have these sensations in their legs? Who would be their primary caregiver? If they are maybe seeing, at the government or private sector, who would they be?
Well, diabetes, I think, predominantly is being treated at the primary level, except for those that are not well controlled, then they end up going to. So at the state level, obviously, there is a huge burden of disease and they can't cope with the numbers. But what we see at our level is if we can control the diabetes and catch it early, and nowadays we got actually a more refined way of diagnosing diabetes. There's a category called pre-diabetes. So any slightest suggestion of a diabetes symptom, we would screen. And then again, we do a lot of just plain screening at a younger age. In the past, when I was at medical school, they said, okay, don't worry about diabetes until you're like 40, 45. We don't say that any longer. We check for everyone. And again, just coming back to Prof's point, when the children, they will have other symptoms possibly. Also, the other thing is, and I'm going to harp on that point again today, it's a recurring symptom. So even if it's not the pins and needle, but another symptom of diabetes, if it is, and generally with children, they present a lot with fatigue and tiredness and unusual, out of keeping. And children are generally very active. And then again, loss of weight. They become quite thin. So those are the kind of things we will look at. The adult group, if we're struggling to control the diabetes, and there's multi-factors, right? There are cultural factors why people don't take medicines. There's a whole lifestyle issue. But once your neuropathy is set in, you know that diabetes has already become a bit advanced. So it's not at a point where it's going to be the first symptom, right? And if it is the symptom that is the presenting complaint, you've got to attend to it much sooner. But Prof, just for me to ask you, like what we find very challenging in our practices, right, is sometimes we'll screen for the common causes, like you have said, the diabetes and the trauma. But we have great difficulty with the connective tissue diseases. It's not something that we will just investigate very easily, especially when it comes to things like lupus and the mixed connective tissue disease, which paresthesia can be quite debilitating.
Absolutely.
So what do you suggest we do?
It's difficult. I'll tell you why. Because if you look at guidelines, they say that if you have a certain symptomatology group, you should do a connective tissue screen. Now, the problem in most environments, it costs an absolute fortune. So if you follow screening guidelines, it will cost you up to 2,000 Rand just to try and find some of these, So I think the answer to the question is that you've got to look at guidelines in terms of the number of symptoms. So if they have, for example, a skin rash and arthritis and then paresthesia, it's reasonable to do it in a younger person. An older person complains and probably don't do it. But costs are an issue. It's not only in South Africa, it's all over the world. The other is, just coming back to what you said, it's the early diagnosis is critical for neuropathy. Now, so the issue is, why do we want to find out? So you get some pins and needles, you can live for the rest of your life with it. But the symptom range can be debilitating. So in other words, you sometimes are unable to walk from here to the end of the room without actually collapsing with pain. And people don't sleep from it, so the symptoms tend to be worse at night for whatever reason as you lie down. Now, at the extreme, so although you have pins and needles early on, you may not be able to feel at all. So in other words, as you put your foot down, you've got absolutely, you can't feel. So it's a numbness is an extreme form of the entire symptomatology. And then what happens, you hurt your feet. As you're walking around, you kick the end of the table or the bed, and then you cause trauma to it, but you don't realize that it's there. And before you know it, you have a massive infection in the leg that spread through half the leg. So exactly what you said, you need to diagnose it early and make the patient aware of it so that he's aware of any little crack in the toe that gets tended to quite easily. And the drugs should only be given when it's debilitating. You don't give it for the mild symptoms of sitting down. The drugs all have side effects, and these drugs are very powerful.
So let's talk about the pins and needles and the blood flow, the actual blood flow that's reoccurring. Is that the only reason why that sensation is lost, because the blood flow has, been lost there?
Well, so blood flow or lack of blood flow is one of the causes for paresthesia or pins and needles. So one of them may be diabetes, which is biologic trauma to the nerve. Another may be an inflammatory condition. But nerves have blood supply, so there's little minor capillaries that run along nerves, and if you knock off that amount of blood supply, the nerve dies, or it depends on the rate depending on how long you don't have blood supply for. But if you knock off your blood supply immediately, so a gunshot wound to the leg, it's quite common in this country, you literally at times have 6 hours to save the leg because the nerve dies first. That's what we call acute lack of blood supply. Sure. At the other extreme, you can have chronic disease. You can have, atherosclerosis or smoking and that sort of thing, which knocks off blood supply. And you do have lack of sensation on a chronic basis. But the more devastating form is acute lack of blood supply, which causes almost instantaneous nerve loss, or what we call, pins and needles, paresthesia, hypothermia.
Yeah.
And there's other symptoms. So when patient comes in to Prof, for example, he's not only going to look at the pins and needles. He's going to ask about the numbness, he's going to ask about pain, he's going to ask about temperature issues. So it's a range of symptoms, it's just not the one alone. He may have different ones in different varying degrees. And sometimes some patients don't make the link in the association that, okay, I had pain before and I managed and I took some analgesic or painkillers and I was fine, but now I'm getting the, so he's already indicating that he's starting, the symptom complex is starting to increase.
Okay, so as I'm sitting here, my legs are going numb because I'm probably in this position for too long, for whatever reason. So what's happening? Is my tablet too? I'm going to move around, stretch it.
I think it's also there's anxiety. We mustn't exclude anxiety from heightening sort of symptoms. We're talking about it. Many people have it, but I can assure you it's nothing serious.
Just thought I'd bring it up randomly. Okay, so some of the questions we need to also look at is other sensations that women often find in their legs. Maybe they're lying on the bed and they just have this numbing feeling. It doesn't often happen. What's happening there? I know we also want to touch on varicose veins as well. Heavy legs, what are the other sort of symptoms that associated to legs?
Look, if we're talking about varicose veins, that's a complete different disease process with different symptomatology. But I think if we say numbness, in other words, we use that word that you can't feel or you're feeling pins and needles or it's tingling, the primary problem is a nerve. Whatever the issue is. If we talk about heaviness, then that could be varicose veins or leg congestion and venous hypertension, which is completely different. Now, pain at night is such a complex thing because there's restless legs, there's people not sleeping well, there's cramps because you exercise during the day. So, and if people are unsure and the symptoms are debilitating and serious, they need to have it checked.
I don't know. Sorry to interrupt. Can you just elaborate a little bit about restless legs? Because, at social functions and people talk, they talk to the doctor or to whoever, and they say, we got this restless legs. What do you suggest? What is the actual thing? What is restless legs?
If we had a very clear definition of it or an etiologic concept, then we would know about it, but unfortunately we don't. So, if I say, what is a restless leg? So somebody would say, well, it's an involuntary jerking action. In other words, I've got absolutely no control of it and it kicks off.
Does it.
Now so we're talking about sensory nerves now providing pins and needles because it's irritated or inflamed. And generally that's because a motor nerve, so something that causes you to move, has been stimulated for whatever reason. Now, we need to separate that. So you can be asleep at night and suddenly you move your leg. So that is because a nerve stimulated a muscle and you moved your leg. But in all of that, you do get irritation of the muscle alone. In other words, muscle, for whatever reason, is excitable tissue. So you can touch it on a blanket and it will go into a bit of spasm. Now, a lot of those times, and I would hazard a guess that 80% of the time, it's not pathological. In other words, you're not going to lose your leg or you're not going to get a permanent disability.
It's a really crazy feeling, though.
It is,
It's scary. What's happening?
You're absolutely right. It's scary because people heighten that, So then you go to a doctor repeatedly and he just gives you something and it goes away and comes back. And sometimes...
And they need to just, basically it's unknown. So you need to kind of understand what is happening to my body. Talk to your leg.
So what happens, like Prof is saying, once you explain to the patient what's happening and give the reassurance, and at times you end up having to do investigations, and that's the danger because you sometimes over-investigate and you may find nothing, or sometimes you find a red herring and then you're going on a different pathway. So again, it's a lot to do with the communication between patient-doctor.
And giving the correct information to the patient, to the doctor as well. Okay, we've got some questions that has come in. My mother has lately been experiencing pins and needles in her left hand. She can't pick up heavy stuff and hand hurts when she does anything strenuous. She hurts that hand when a heavy door, closed on the hand, so there's trauma. Does she need to see a doctor for this?
Yeah, I think she does.
Yeah.
She hasn't indicated how old, but I'd assume, somebody who's elderly.
Yeah.
Now, there are lots of things that can do that. So it may be a nerve injury, but it could be anything. She could have clotted a vein, she could have hurt the injury. It could be what we were talking about earlier, carpal tunnel syndrome. It could even be trauma to a neck. So if it's unilateral, so it's a rare form of, let's say, pins and needles. So pins and needles are usually affect both limbs if it's not that serious.
Okay.
But if it's just affecting one, then we call that an atypical presentation. So it could be related to something harmless, or it could be something that's more serious.
I'm going to have Dr. Yaqub also comment on that question after this break, because usually he's the first port of call that this mom would visit. We are talking why we get pins and needles. What is this numbness? What is this jerking sensation that our heavy legs that women often get? If men, you're suffering from it, please do interact with us, and you can call us on the number on the screen. We'll be back just after this. Assalamu alaikum wa rahmatullah. Welcome back. A very good evening. Thank you so much for joining us as we talk pins and needles. What is it? Why do we get it? What is happening? We have Professor Pillay, vascular surgeon, in studio with us, as well as Dr. Yaqub, our resident medical specialist from the IMA, and we appreciate your time once again talking to us about the subject. So just before the break, Dr. Yaqub, we mentioned a viewer telling us about, the experiencing of pins and needles. She can't pick up heavy stuff. She did hurt her hand. And usually, as Professor Pillay mentioned, first port of call is go and see your doctor. You have to go, because that's what you want to know. Does she have to go and see your doctor? But what does she need to know when she comes to visit you? Because often they miss out on information, they forget stuff. Just as a rundown.
Look, we don't have a long enough history.
Yes.
We just have a question. So again, we still don't know the temporal relationship between the time of the injury to the hand and her symptoms. So that's the one. And sometimes patients, and even people generally, may attribute something to that particular symptom. So maybe they're attributing the trauma to it, but it could be something else. So when they come, obviously we'll again do a proper history, a physical check. It just could be a fracture that has either not healed, that they didn't pick up, a small little needle hair stick fracture. So it'll obviously require, but the fact that she's symptomatic, she's got the pain, she must consult.
Okay. What are the solutions for her?
Well, the solution will be depending what we find. So it will depend what we find, right? So whatever we find, we'll attend to that. Yeah. So the whole thing about medicine, obviously, the primary aim in everything that we do, we try and establish a cause. Yeah. And where we can find a cause, we attend to the cause. That's the thing. Only then, later on, we'll say, okay, this is of unknown origin, which in medical jargon, again, we say like idiopathic. But that is towards the end.
Okay. Professor, did you want to add anything?
Yeah, I think we must be cognizant of the fact that it's a hand.
Yes.
So we're getting a little bit of information, but if you say ignore a hand or take it lightly, you lose the hand. Simple as that. Yeah. Now, whilst we're talking about a fracture, which can be easily treated and you'll have a normal hand, the exact symptomatology can mimic a stroke. So you're having a partial stroke. She can't, so she loses. Although you're saying you hurt the hand, so you're losing sensation.
So much.
So there's a lot. So you've got a whole gamut of things to go through. So it really needs an investigation.
And sometimes people are having strokes and they don't even know.
Correct. Yeah, we call them transient ischemic attacks, which is like a pre-stroke, and it can go missed, like Prof said. So,
have yourself checked out. Okay.
Definitely.
So another question specifically now to the pins and needles and feet. My feet feels like a bandage is over it, and of course there isn't one. If I walk with a slipper on, and then it comes off, she doesn't feel it coming off. I have been to the doctor and I'm not diabetic, so don't know what's going on or what's wrong. I feel if I cut myself tomorrow, I won't be able to feel it. Professor?
I think, you're saying it so clearly, and that's almost a textbook description of paresthesia. That's exactly how people describe it. In other words, it's a bandage around the legs. It's just, it's very clearly stated. So I'll cut myself so she's definitely got a neuropathy of sorts. It's very, very clear. Okay. The only issue is identifying what's causing it. Okay. Now, she sort of mentions both legs, is it?
Yes, no, it's just one.
One leg. Yeah, it could be a whole host of things.
I'm gonna unpack that answer just in a minute. First, let's take our caller. We have one online. Assalamu alaikum. Good day. This is ITV Health Matters. You have a question for our prof? Hello. Okay. our lines are open, so you can call us at the number on screen. We do ask you, if you're calling in, please turn down your television, because sometimes you think you're listening to me on the TV and you're not able to answer me. So please, if you're calling in, turn down your volume on your television so we can continue having this conversation, and your questions can come in live in studio. So just quickly, if it is that she's saying she doesn't feel it, and you're saying it is of great concern, she has to go and say, what are the sort of tests and procedures that she need to follow?
Before we even go to that, we've always told to take a good history.
Okay.
In other words, you find out whether she's got thyroid disease, whether she said she's not diabetic, but you pointed out as pre-diabetes. Now, all that means is that you have a risk of developing full-blown diabetes, but we do know that paresthesia can affect pre-diabetic patients as well. Then I think from her perspective, the way she points it out, it could be a nerve entrapment of her back. So you'll find out whether there's backache and what her weight is and whether there's pain when she's lying down. And then take it from there and do a whole lot of other biochemical tests to find out what it is.
It is quite worrisome for women to say, listen, I mean, for this possible
advice to this patient and this person is they mustn't delay their visit to the doctor.
Okay.
So maybe as early as tomorrow.
Yes, because I was just going to say, she says she cuts herself, she doesn't feel it.
And to go in a fasting state if possible in the morning.
Okay.
It's not to have anything, just drink some water and that's it. And just do that first consult in the morning.
Well, I think just to reiterate, she says she has been to a doctor and he hasn't found much.
Yes, she said she has been to a doctor.
If she's, I think that if she's got no obvious cause for this, she should probably cut the line and see a neurologist.
Yeah, and get referred.
To a specialist.
To a neurologist.
Neurologist.
Yeah,
okay.
Yeah, that's right.
All right, so the big question is, why do mostly women complain of these sensations?
You take that one.
I want to know, Dr. Yaqub, tell me. Because I look at my husband and he sits in the same position, and he's sitting in our prayer position, which we do our sujood, and we're making dhikr, and he's doing it for a long time, making prayer, and he doesn't have any problems with his feet, and I've got this pins and needles.
So whatever answer we give you must be based on some sort of science or some sort of evidence, otherwise we're guessing. So I can tell you now, there isn't a study that's isolated sort of non-serious pins and needles from males and females, but you can make some guesses, and I would think that the muscle bulk, for example, in males is greater, so they have greater sort of strength that will keep nerves apart and prevent the inflammatory process, etc. That may be one thing.
So it's just a very nice way of you telling me I need to exercise. Let's talk about that. Is it a lack of exercise? Should we be walking more and more circulation? Tell us about that.
Well, not so much circulation, but the better your body tone is, so your muscle strength, the skeletal structure, the less chance of you entrapping a nerve, whatever reason. So to put it differently, if you are diabetic and you have what you call a diabetic neuropathy, so you want to give a drug to try and allay the symptoms. But one of the things that has been shown to help is exercise. So moderate exercise strengthens your body, strengthens the muscles, and takes away some of the nerve pain. So exercise in any chronic disease process is valuable.
Okay. Is that what you offer, the advice that you offer when there is no solution possibly?
I think in terms of exercise is part of lifestyle. So wherever we can remind patients or emphasize the point, we will do so. And it's an important aspect of your overall management, right? And again, like Prof said, we don't just rush into drugs unless you just want to give some kind of symptom relief for a few days or whatever. But we're still going to look for the cause. But exercise is not going to harm anyone. But again, they need to also know their capacity to do certain exercises. Because we get quite a few patients that have got chronic arthritis of their knees and things, and no point telling them to do that kind of running or whatever, but simple exercises, walking. We also work quite closely with our other modalities who strengthen the core, things like the biokineticists and the physiotherapists. But again, we touched on it very early again, affordability is a big issue in this country. So it just so happens that this kind of burden of disease in diabetes, HIV, TB, the causes for neuropathy tends to affect the more lower socioeconomic groups in many instances, and sometimes it's the other. So so it's always a multimodality treatment.
Absolutely, and lots of history, as you said. So the caller earlier on that we've missed, 67-year-old experiencing numbness only when sleeping, No matter which side I turn, I get numbness. I previously had gone for an X-ray because they told me I had a vein problem, but the X-ray was clear though. I want to know if I can travel, and also had a hairline fracture and pinched nerve some time ago. Okay, so she had a hairline fracture and pinched nerve a while back. Professor?
Well, we assume that hairline fracture and pinched nerve was in her back. Hasn't
I
said.
am not clear.
Yeah. And then we assume that the pins and needles is in her lower limb.
Yeah.
I mean, that's a sort of common scenario.
Numbness, yeah.
Now, again, because she said she had a fracture, we'll sort of hone in on that in terms of investigation. And when you lie down, you put a bit of weight on your back in that area that's been traumatized before, and then the nerve becomes affected. But vascular disease, in other words, lack of blood supply, can present exactly the same way. So when you lie down, there's lack of blood supply to your extremity. So that needs a little more investigation.
Okay. So again, she needs to go and see a specialist, not just the GP.
No, I think a GP. If she hasn't seen a GP before, it's reasonable to see a GP.
All right, we have Zahir online. Assalamu alaikum. Welcome to Health Matters. Zahir, okay. Zahir dropped the call.
Previous caller, right? She has a doctor.
Yes.
They've done X-rays. They've done some kind of attempt at investigating, right? So there could be a bit of a longer history. So perhaps to go back and see where she is in terms of,
So history. All right, a 44-year-old woman. I have for years suffered with my knee getting locked. It would get stiff, and I'm unable to move. I wake up in pain, screaming, and unable to move. I have to use arnica gel to ease the muscle. What is causing this? I haven't been hurt before, and I don't have a chronic illness.
So it's one knee that's giving a problem when she lies down. That sounds like an orthopedic bone problem. You know, she probably has very poor cartilage between her joints, and a locked knee is a painful, devastating thing. So it usually doesn't give you paresthesia and pins and needles. So you get into a certain position, you may even dislocate it because your muscle strength isn't there, and then you get back, and so she needs to have proper X-rays. Probably advise her to see an orthopedic surgeon.
So procedures to first go and see the orthopedic surgeon, and then going to have the necessary X-rays.
Sort of clear history.
Interesting. And you think that you'd possibly have an injury? Is this because of age? She's 44.
No, there are lots of. You can have connective tissue disease where some of the connective tissue and the ligaments are not strong enough. She may have hurt it a long time ago and only realizing the ills of it now. So it could be numerous things that are that are wrong.
Great. So just to remind you, we are taking your calls. The number is on your screen. And when you are calling in, please turn down that volume. We are unfortunately losing calls and having a problem. So do speak to our in-studio producer as well to take down your questions. The number is on your screen. So let's look at the tests that needs to be done. I know that you said history. We need to know about the patient. Genetics, does that fall in play when you talk about history?
When you mean inherited disorder that's causing...
For the, whether it's diabetic or chronic
if you look at, clotting is completely a different scenario, and that could be a genetic issue. But diabetes, for example, so if you look, there are two types of diabetes, if you haven't touched on, but type 1 and type 2. Both of them have a reasonable genetic component to it, so an inherited component. It may not be that, the rate is not that high for type 1 when you get it early on, but certainly for type 2 there's a genetic component to it. Now, in terms of tests that you do, if you're referring to the entire range of causes for pins and needles, from alcoholic liver disease to B12 deficiencies to thyroid disease, so there's a whole host of them. So you tend to sort of screen patients and do just the tests that are relevant to a single patient. Otherwise, you run into
crazy,
money
one to
issues.
the other. Okay, when we get back, I want to touch on, and I know it's a completely different subject, but it is related to the lower limbs, and that is varicose veins. So how women should be managing that when they do have an issue. We have vascular surgeon in studio with us, Dr. Pillay, as well as Dr. Yaqub. We'll be back just after this. Assalamu alaikum, good evening and welcome back. This is Health Matters in our last few segments as we lastly discuss pins and needles, the sensation, the numbness, and we try and get some sort of understanding on it. But also we want to touch on Varicose veins. Varicose veins, what is it? How do women manage it if it's not painful? Is it serious? We have vascular surgeon in studio with us, Professor Pillay, as well as Dr. Yaqub. Let's start quickly with you, Dr. Pillay.
It's quite a broad topic, but I think to answer your question, the most important thing is that varicose veins can present in numerous circumstances. In other words, you can have swelling of the leg, and you can have pins and needles sometimes, or heaviness of the legs. But we must make it clear that varicose veins in its broader context doesn't cause you to lose your leg. There's very poor association between that and significant medical clotting, deep vein thrombosis. And many a times people are born with visible veins. So in other words, so we often say that you're likely to be born with an abnormal vein than a normal vein. In other words, all of us have different roots for these veins. So you often get people coming to you because their veins look a little blue or sticking out a little more. Those are not varicose veins. So by definition, what a varicose vein is, it's an abnormal, tortuous, enlarged vein without a valve. So you have little valves in veins that promote one-way flow of blood. For whatever reason, if that valve, like a motor car valve, if it's not there, you'll have backflow of blood and these veins stick out, and they'll become more tortuous and more visible over time. Now, even if it looks horrible, if it looks like a rope, if it looks the size of my hand, it really is something that doesn't kill you. Doesn't, and people don't understand that. They see it and they panic and they think it's going to cause a clot in their lungs, etc. And oftentimes
it looks scary,
and people rush them into surgery, to remove the veins. And we were discussing it earlier as to, how to manage those things. And it's not always that people need varicose vein surgery. I think at times it's overdone, over-prescribed.
There's something cosmetic.
Yeah, it could. I mean, it may give you symptoms, but so what's happening in a varicose vein is blood is flowing in the opposite direction.
Oh.
So instead of it flowing upwards towards the heart, it's sort of stagnating towards the lower limb.
Okay.
And if you put on a compression stocking, for example, in the majority of patients, especially if they're old and have lived with it for 65 years, that's all they need, instead of a very expensive operation that carries significant risks.
I want to talk about, how GP can help women manage it, but just quickly,
a question. To interrupt you, it's not only in women, eh?
Absolutely, yeah. It's not
really?
No, absolutely.
Okay. So you've seen men with it as well?
Yes, definitely. Okay. And it's a well-known fact, like wicket keepers in cricket are known to develop that, because if they have been born with that incompetent valve that Prof spoke about, and because they stand, especially those that were playing test cricket, right?
Yes.
We're not talking about this new T20 version, okay?
quick.
So where they've stood for a very long time, they get the stasis, and over time, their veins tend to swell up a bit, and they feel it, because you see it's the dead blood that stays behind. Your oxygenated blood is supposed to take you back to the heart, so it's all venous. So that's what Prof is also differentiating, that firstly it's a superficial system of your venous venous system, and therefore it's not like fatal, but it can cause discomfort. And the simple solution in most instances is to try and compress it so that at least some of that compression is assists.
Okay. Very interesting. A 62-year-old female diabetic on insulin fell in her backyard 2 days ago. 2 days later, she noticed swelling in her foot. The X-ray showed a fracture in her toe. The swelling on foot came down, but the toe is still swollen and black. I'm stressed out because I'm diabetic and the toe feels numb. Please help. Professor?
We must point all of it towards trauma. I mean, she's had a fracture of the toe, which is significant injury. Now,
and she's diabetic.
Yeah, so, I mean, if there's no tear in the skin, in other words, there isn't an open wound, then it's unlikely to be an infective source. So if she complains of a change in color, it's likely to be that she's caused a bit of, she's caused some trauma to it. So there's a hematoma or some blood collecting at the area, and there's probably nothing, to worry about. But in saying that, she's still diabetic and there's a fracture, so I'm not sure how she's managing the fracture. In other words, is somebody put a splint on, or they said just, leave it for a while, but that needs to be...
And the black...
it's the clotted blood, most likely.
It's like a bruise, for example.
So she needs to obviously see what type of fracture it is.
Okay,
because sometimes you get a simple fracture which you can manage very conservatively, and sometimes more than one piece is broken into little small parts, which can obviously then needs a bit more intervention. And being diabetic, she has to be careful that skin doesn't break open, and other things.
So if she's being managed at the government hospital, what should her first protocol go to a GP or just make an appointment?
They would have a look at it. It's just interesting that we leave out the most important thing, and that is why did she fall?
Yes.
Yeah.
So here's a diabetic that's fallen,
exactly.
and diabetics have an inability to feel. So she could not be feeling. I mean, unless she tripped on a plank or something, but if somebody just fell, it could be just that she's not feeling. So she has paresthesia, which is not treated adequately. Or pins and needles or that kind of augmented issue, and
diabetics also, they have, you have 3 nervous systems, right? And there's one that's called the autonomic nervous system, which we don't control, and that gets affected by the diabetes, which can also drop the blood pressure. So again, we don't know whether she got dizzy and fell because of this autonomic nervous system, if she had a sudden fall in her blood pressure. And diabetes is a multi-system disease, so why she fell, again, is her sugar controlled in the first place? Or did her sugar drop to such a level that she fell? Right, so those are
going
important
really
things.
deep into it, eh?
Yeah.
Thanks, guys. We have to wrap up. We've got 2 minutes. Professor Pillay, thank you so much for your time. But in conclusion, what message would you like to leave the viewers with regards to the way forward with pins and needles, the numbness and sensations?
I think if there's a message to take home, I think the population that we have that's diabetic is massive, and the complications of diabetes in terms of the limb are life-threatening. So if you have an infection in the toe, it's life-threatening. So I think, and oftentimes you don't even know that you have a neuropathy. You don't. You walk around on a daily basis and you don't feel the pain. So I think that almost every diabetic who's had long-standing diabetes for, let's say, 5 to 10 years, I think it's absolutely mandatory to see a GP to be assessed for peripheral neuropathy and diagnose it at a very early stage. Because if that sort of education is given to them before they get the injury to the toe like her, and before you get infection in the toe, and before you have lack of blood supply, you can pick it up very early. So your limb loss rate will be, so you screen appropriately at a very early stage, and then get the education as to how to look after your feet at that point in time.
Does the GP help manage
so just to add to that, so we are emphasizing on the main cause of pins and needles in the diabetic patient in our context. Is that right, Prof? And what Prof is referring to is what we call a diabetic foot. And we need to, and we have definitely screening protocols in general practice. At least 6 monthly to a year, we do certain tests. And testing for the peripheral neuropathy is part of that screening. So it's not just looking at that sugar level at 6.7 and patient tells you, every morning I checked it and I'm fine, and I only get a high thing on a Monday morning after I've attended a wedding. They got to understand, and I think getting an understanding and insight into the disease is very, very important.
An absolute pleasure having gentlemen in studio with us, Dr. Yaqub, Professor Pillay, all the best, and thank you once again for being here. Assalamu alaikum and good evening. And from myself, a big thank you to all our viewers. Apologies again for the telephone lines, but next week hopefully we'll get our WhatsApp line up and running. A big thank you to our producer, Najma Bibi, as well as our in-studio staff, Mr. Johnny and Kabir, and a happy birthday to his little ones. Shukran so much once again. From myself, Hawa Solomon, wassalamu alaikum and goodbye for now.